So, welcome everyone. Thank you for joining today's meeting. Before we begin, I want to confirm quorum. And then Mitch, if you could please do roll call.
No problem. Because I love doing this. Chair Jokinen.
I didn't mute myself on purpose. Present.
Katrin Yount.
Here.
Did I do it that time?
Yeah.
Two for two. Okay. Amy Nort, or excuse me, Art Zamudio. Lisa Weigum. Amy Nordstrom.
Here.
Mike Obiero. Joe Bezeggi. Oh, he's there. Oh, I think he might have froze. Come back. Fernando Pena.
I'm here.
You. Judge Rigmaybe.
I'm here.
Heather Jeffries.
Present.
Christy McKinney.
Here.
Moxie Loeffler. And Co-Chair Bukai. We have one. We do have quorum.
Awesome. Thank you, Mitch. And just a reminder for anyone who would like to make a public comment, please either send Mitch. Sorry, I lost everybody for a minute. Mitch, direct message or note in the chat. We have reserved time at the end of the meeting for public comments. Since we have quorum, we'll move into the agenda items. So I'll hand this over to Director Dolph to share updates.
Thanks, Katie. I'll do quick updates and then I will give our new staff member, Ashley, a moment to introduce herself. As Mitch alluded to earlier, we are very excited to have Ashley Olson on board, and she is raising the bar for us very quickly, which is wonderful, so that we won't drop some of these balls that we sometimes drop. But first, I'll just give a couple of quick updates. The commission met earlier this week. We spent most of our time hearing from OHA about the Rural Health Transformation Program and how they're working with us to align some of the funding with the comprehensive plan. So if that's something that you are wondering about, I highly recommend taking a look at the commission meeting and just checking out what OHA is up to. That's been a really neat alignment, such as it is with this limited funding with a bunch of strings. So that was on Monday. Next month at the commission meeting, we are going to spend the entire time doing a quarterly update. So we are coming upon the end of the first quarter for the comprehensive plan, and we already have exciting things to report on. So that's the good news. Mitch will probably talk a little bit more. We've been furiously building out the work plan and figuring out how to track it and meeting with all of our partners. It's been a busy quarter, but we're off and running with that. So all of your work last year was worth it, and now we're actually implementing the plan. So more to come next month on that. Let's see, opioid settlement board, just a quick update there. I know several folks in this group follow kind of their actions. The opioid settlement board has $10 million left as of right now to allocate for the remainder of the biennium. And I shared last month, we had planned in January to do a deep dive on what we were going to do with this biennium spending, but ended up lessening the gap for the Behavioral Health Resource Network grants. We started talking this month about what we're going to do with that 10 million. And we'll hopefully come to some decisions next month. Fernando Pena also sits on that board if you have any questions from us. We are still waiting. There are still some outstanding settlements. So I will just kind of flag for everybody, there's going to be another chunk of money coming. So you remember last biennium, we had this big chunk of money, much less this biennium. There's going to be another big chunk coming. So please pay attention to what's happening locally as well. 55% of the funds go locally. We just posted the most recent annual report where you can see where the funding is going locally. So just want to give the heads up on that. And I think that is really all of our updates. So I will turn it over to Ashley to introduce herself.
Hi, everybody. Can you hear me okay? Good. Hi, everybody. I'm Ashley Olson. This is my third week with ADPC. It's really great to be here supporting you all. Right now, I'm a sponge, just learning everything. I am about 2 years into state work. I come from the Higher Education Coordinating Commission, where I supported the Oregon Youth Works Advisory Board and sometimes the WTDB and the Oregon Service Commission. I went to the University of Oregon, got a psychology degree, and again, I'm just happy to be here working with you all. And it's going to be great getting to know you. So I'll be sending emails and assisting you with Workday probably a lot. So great to meet you all.
Awesome. Thank you for the updates, Director Dolphin. Nice to meet you, Ashley. We're all excited you're here. Okay, so we'll move on to our next agenda item. So we have a committee nomination. The details, do we have a slide with the details? Okay. The details are on pending slide. And adding Beth brings both rural and addiction medicine expertise to the team, which helps address some of the implementation challenges we've identified. And unfortunately, Beth could not join today due to pre-planned clinical obligations, but if the committee approves her nomination today, she will be an active participant moving forward. I will wait a few minutes just to make sure everybody has that read. So is there a motion to approve the nomination of Beth to the committee?
I will move to nominate Beth Williams as would be wonderful to have a nurse practitioner to the committee.
I'll second the nomination.
All right. It has been moved and seconded that Beth be added to the committee. Is there any discussion? All right. Hearing no further discussion, we'll now vote on the motion. Mitch, do you want to go around and okay.
No problem. I'll go back through just in case some folks have filed it in since roll call as well. So I'll call you even if you weren't here just to check. Lisa Weigand. Katrin Yund.
Yes.
Allison Noyce is out of the office today, by the way. I don't know if I mentioned that earlier. Art Zamudio.
Yes.
Amy Nordstrom.
Yes.
Mike Obiero. Joe Bezegi.
Yes.
Fernando Pena.
Yes.
Judge Rigman.
Yes.
Heather Jeffries.
Yes.
Christy McKinney.
Yes.
Moxie Loeffler.
Yes.
Co-Chair Bukai. And Chair Droken.
Yes.
See, I fooled you that time. I went last.
I know, I was waiting. Awesome. So it sounds like the yeses have it and the motion is adopted. Beth is officially approved as a member of the committee.
Thank you all so much. And I want to also kind of after the fact, on Bradley's behalf, mention that he was going to, as somebody who knows Beth, was going to abstain from that decision, but was very excited that her name was kind of thrown into that. So both the wealth of her current experience, but also historicals. Go ahead, Katie.
Okay, I was just going to ask. I don't see Bradley. I wasn't sure. Okay. So today we are joined by Amber Cheney from OHA, who will present an overview of the Reentry Healthcare Program. And this program aligns with our priority areas, particularly addressing the health needs of justice-involved individuals transitioning back to the community. Amber, I'll let you take it away.
Hello, all. Can you hear me? Okay, perfect. And I should have the ability to share, so we will check my technology today. All right. Is it there? Oh wait, hold on. There we go. I had to hit the share button. I have not used Zoom in a minute. I've done a lot of training on Zoom. I'm working for Oregon Department of Corrections, but I have not done so recently with the Oregon Health Authority. So thank you so much for having me here today. I work a lot with Mitch. I love working with Mitch. So he's brought me into stuff. I bring him into stuff because I think that this is we're all playing the same game and trying to like advance the healthcare initiatives across the state for individuals. And that is my primary goal. So I work with the Oregon Health Plan on a special project. We call it the the Reentry Healthcare Program. Some of you may have heard about it. If not, I'm going to tell you all about it. So I work with Medicaid and the 1150 Medicaid waiver facts. I always like to step back when I'm doing any presentation and just try to explain what a waiver is. Granted, you probably all know, I just step back for this waiver though. And just there's federal laws that govern Medicaid, and we have to ask for a waiver in order to be able to do things. For instance, pre-release services to individuals who are incarcerated. And Oregon, so there's a Medicaid payment exclusion law that's been in effect since 1965, like around the Social Security Act, which is just crazy that it hasn't been changed yet. But there has been laws recently pushing for and demonstrations already providing services to people while they're incarcerated, which is fantastic. Oregon got approved in 2024 to provide up to 90 days of a limited benefit package to individuals who are incarcerated, which is awesome. We had our best intentions to roll it out, and it was going to be a great program. I'll tell you about what services we were going to have. And originally we were going to have service level 2, which of course this group probably would have had an impact on for sure. MAT was going to be a requirement for any participation from any facility across the state. And they had to ensure that all individuals had 30 days of medication upon release, which, as most of you in the system know, that could have been, these benefits would have been fantastic. A lot of jails and Department of Corrections are already doing this, but this would have allowed for Medicaid to come in and reimburse them. And I'm imagining it could have just astonishing impacts across the counties, the jails that are trying to do these benefits on their own budget, because right now they can't bill for anything. So it was great, and there was a lot of jails that were really super interested in these services. And then we had expanded our services to include additional things on level 3. So and with participation, you could get capacity building funds. So there was a lot of great things that were going to happen with this program. So those are the services. We're still implementing service level 1, which I'm going to go more into. We decided we as in the Oregon Health Authority, 1115 waiver team and Medicaid leadership decided in October of last year that we just couldn't, the state could not roll out waiver services within this demonstration, which is from 22 to 27, due to system limitations. A lot of things came down the pipeline from HR1. So our eligibility teams and our systems definitely had to shift a little bit of focus, and the amount of data that would have had to be passed through our eligibility system into the carceral system, it was just too much of a lift. So we are not implementing during this waiver cycle. So that was really unfortunate. If none of you had heard of it, sorry to burst that bubble. That didn't happen. But what we are doing, so the Federal Consolidated Appropriations Act, I'm sure a lot of people don't know a lot about it unless you're like right here in this world. And because when we got the waiver authority, our service level 1 of the waiver covered all of these services under the Federal Consolidated Appropriations Act. This was an act that was put in by the government into law in 2023 that required mandatory services for youth releasing from carceral settings. And this is any carceral setting in the state, and it's up to 30 days pre-release and 30 days post-release. And to walk back and say youth, what is the definition? Because I was reminded when I was in a meeting this week with Department of Corrections that youth has a lot of different definitions. Where this is youth under the age of 21 or under the age of 26 and aged out of the foster care system. So again, different programs, different programs and agencies and such classify youth as different, but that is in this act, that is youth. The services are included. I'm going to go more into depth about them, but it's just target case management and screening and diagnostic services in alignment with EPSDT, or the early and periodic screening, diagnostic, and treatment. And so these are the services that are mandatory, that the authority or the health authority of the state is required to offer to individuals across the state upon their release, or 30 days prior to the release and 30 days post-release. Am I going too fast, or is that making sense? I think there's a hand
I had
raised.
one question already. Yeah.
Yeah.
Thanks, Amber. Hey, and just to clarify, we weren't doing that previously because we had a waiver not to do it. Is that correct?
No. So great question. So prior to June of 2024, it's against the law for us to do these services pre-release.
Right.
And so this act changed the federal law, but Oregon still had a statutory law that prevented us from doing it. So
Okay. That was
yay,
wondering.
we
Yeah.
just
Removed.
got in this year with House Bill 4040, it just got adapted. And so we just got authority to provide pre-release services as of 2027. So we did it. That was a big lift. So now that there's that in effect. So we have statutory authority both federally and state as of January 1 of 2027. So that was going to be another barrier, because last year we had put that up in one of the OHA Medicaid fix bills, and it got dropped. So we didn't have so currently right now we don't have statutory authority to provide services, even though federally you can. We all know how federally and state and how those things can not always meet eye to eye. But great question. So I'm going too fast. Okay. So the program scope and timeline. So in the FCAA law from 2023, the CMS started requiring compliance starting January 1st of 2025. And with the changes in our program last year, our original implementation date with waiver was going to be January 1 of 2026. When we figured out that we weren't able to do the waiver full implementation, we had to focus on the FCAA. So what we've been doing since October through currently, we've been obviously scoping much smaller and focusing on post-release services, the 30 days post-release services for the eligible youth across Oregon. So we're working currently with the facilities, trying to roll out those post-release to connect the community to their CCO upon release. So that's what we're focusing on, and now, especially since we got statutory authority. And no earlier than January 1 of 2027, we're going to start having the availability of billing pre-release services, which again, has never been done in the state of Oregon. It is being done though successfully in California, and it's being done successfully in Washington right now, which is pretty encouraging. There's a lot of federal chit chat and bills that have been put forth in the last few years to remove the inmate payment exclusion altogether. So that could be, I think that there's a lot of work that's going into this. And I didn't go, which I think is super important. The reason that they put the federal consolidated appropriate, there was a lot of research that went into this, and there's been a reduction in juvenile corrections over the past from 2004 to 2018, and it's like a 70% decrease, right, in the juvenile locked up population, which is fantastic. But this is what the services were based around, was they found that what has been effective for youth and what has been helpful in reducing their recidivism, going back into the system. And these are the services that they really focused on. So that, just a little bit of history of that, is really important to know why they came to these specific things, these benefits, because obviously there's so many more benefits out there that they could have included, but this is why, because these were proved effective to reduce the recidivism. And a fun fact, Oregon is 7th in the nation for highest amount of individuals under the age of 18 locked up. I don't like being high in those kind of things, and that is including DC. So it's not a very good statistic. It's kind of ugly for Oregon locking up our youth, being 7th in the nation to lock up our youth under 18. And as we all know, the younger you're incarcerated, the more likely that you're into the system for longer periods of time, and then having poorer health outcomes. So this is hopefully a step in the right direction for the whole country. Again, that's our scope. We're going full compliance, hopefully by the end of 2000, or the end of the end of 2027. Sorry, because right now we're not doing the waiver. So the FCAA and the waiver, we had them married together because it's the same population and services, but we've obviously had to separate them because FCAA is mandated by the federal government. So this is going to be a program that's going into effect without the waiver. To zone in just a little bit more about the services, so we have targeted case management, which includes a comprehensive assessment of needs, a person-centered care plan, and then referrals and activities that are identified in the person-centered care plan. And then the follow-up activities are to ensure that the plan is implemented. And 30 days of post-care coordination is included as well. And the screening and diagnostics in alignment with EPSDT, which is already a law currently in Oregon, I believe, for anyone under the age of 21, don't quote me on that. That's already being done for this population as well. The caveat to pre-release services is that it does not include the treatment piece. So when our facilities are able to bill, sometime in 2027, they can bill for everything but the treatment piece. So that's an important note, because I know we've had partners asking about that. Well, maybe we could get this to be paid for, like the treatment for one, like Brixadi, very expensive medication. And I've already been asked if these benefits would cover that pre-release, and the answer is unfortunately no. But the day of release, they should have their full OHP benefits intact and be able to get it on the day of release. So that it's a little bit of a positive thing. Another positive thing with the benefits of an individuals getting their benefits turned on early is there is usually a delay of when you're going from a facility to the community to get into your your CCO. And so that delay is gone at that point. And so that's kind of a really cool thing. So it's decreasing that transition of care period that's usually not pretty how it works out with your care. It's harder to get your doctor's appointment scheduled and everything if you don't have your CCO intact, your benefits intact. So that is going to solve a little bit of the gap that's currently in the system for this population. So to focus in a little bit more, the health risk assessment identifies the physical health needs. So it focuses in on prior and current health information. And all of these things are done or supposed to be done as far as like the health risk assessment by a qualified provider. And that could be from employed by the CCO or meeting the definition of that. So the CCO though, or fee for service, are required to get these services for individuals. So how that looks and who's the provider will be up to the CCOs and how they do that. Once we have pre-release services, I know there's a lot of facilities that are interested in doing their own services, their own pre-release services, and their own like targeted case management. So as long as they meet the definition under our rules, then that they could definitely do that. And these are identifying the need for these things. These are not getting these things pre-release. So that is a definite distinction, but it is getting you access to your treatments and your vaccinations and things like that of this age group. And then there's our reentry healthcare plan. Oops. Oh man, my mouse is crazy today. So the reentry healthcare plan, CCOs have the ability to use their own care plans across the state. We have a template, but most of them already use their own. As long as it meets these needs, they can use a different format. So if you're in the community and you're providing services, it's possible that each care plan doesn't look exactly the same. As long as it has the components, that's the goal. So these are the things that it covers. I'm excited to see the medical, the mental health, the substance use issues that are being addressed for this youth population. Because again, there's been a lot of research showing that if you help them get treatment younger, they're not going to be offending later in life. So hopefully this, again, it helps with that population. There's 63 facilities eligible across the state, including the federal prison, which has opted not to participate at this time there. So we haven't really done any engagement with the prison in Sheridan. I'm currently a liaison for the Oregon Department of Corrections and the Oregon Youth Authority, and kind of 15 of the jails right now because we had some teammate transitions. So we have different liaisons on our team that cover different populations. And I like I said, I do the agencies. The distribution, so who's getting these benefits or who's eligible across the state, it's not a ton. 123 people isn't a ton, but if you think about the impact that could make, the ripples that saves could be pretty big. These are going to be, unfortunately, an overestimation because it's really hard to know the population that's from the ages of 21 to 25 because we don't know how many have aged out of foster care. So that the numbers are a little bit inflated at this moment because we're averaging and kind of guessing. The only one that we're pretty certain on is the Oregon Youth Authority because they house all adjudicated youth. So, and those are the age ranges. So that we're not sure about that. Something that I did not mention that is a huge thing, that post-adjudication is really important for eligibility. So they have to be sentenced, which again is why Department of Corrections and OIA, potentially any of their people that meet the other criteria would qualify because they're all post-adjudicated. But as we know, you're not always post-adjudicated in jails and county detention centers. So that is another unfortunate caveat, is that you have to be sentenced. And I today, because I'm a numbers like rule person, I was like, well, what if they get sentenced on this day? Does that mean this counts? So like we're trying to still work out the details of that because we want to make sure, our team wants to make sure we can get as many youth covered as possible and connected to these services because it could be a pretty big deal. But yeah, you can see the numbers across the state, again, probably inflated, unfortunately. The population right here, just on a different, looking at it, like 95% of Oregon Youth Authorities population, and then it goes down the county jails. There's a much, much smaller impact, potentially, because they just don't serve the youth like that as do the others. I think I have a question in the chat. Okay, let's see. I'm going to share the slides. Absolutely. I think Mitch already included them in the invite so that you have access to those. And I am with Medicaid. So I'm under the 1115 waiver team under Jesse Wilson. And then prior foster care youth currently are being identified, mostly self-attestation, but there is on the OHP application, there is a question that asks that, but we are definitely putting more emphasis and working out processes right now of how we could identify that foster care youth. Because again, there isn't like a one size fits all or system, because if they come from another state and they age out foster care youth, technically they still qualify. So and CMS, because this has been asked a lot, accepts self-attestation. So if the youth says that they age out, they qualify potentially. So that is the good thing. We do accept self-attestation. They don't have to like prove it. But they have to actually age out of it. And so that's another caveat. So that doesn't mean I was 12 years old and I was in foster care, but then I didn't age out of it. So that is a caveat. But I mean, I don't think that the eligibility specialists are going to get that like down to the details. So if they were in foster care youth, I'm assuming that they'll probably get the eligibility.
Amber, are
Yeah.
you thinking that you'll try and get the facilities to check that on the entrance into
Yeah.
the facility? So it's in their record right off the bat. Okay, cool.
Yeah.
That's great. And
and
that's great as attestation. That's wonderful. Thank you.
yeah, for sure. Because it's really, there's not a one size, a system that can check anything out of state. Even our system isn't all connected necessarily, because if they're an OIA foster care versus like the child welfare system, like the systems don't always talk to one another. So self-attestation is going to be super helpful and make it a less barrier for individuals to get these services. So that was good that we have that availability. And I'm glad that you brought up about what are the facilities doing now, because I want to explain what everyone's doing across the state. Back in November-ish, I want to say ish because my timeline of when I was able to get stuff out versus my other teammates may have differed a little bit, but it was around November to all the eligible facilities. So we've reached out to all the jails, Department of Corrections, Oregon Youth Authority, and all the county detentions. And each facility got a participation form. They and offered meetings and office hours and things like that in order to see if they wanted to participate across in the FCAA and what participation looks like. And we're working through that still, because there isn't you have to give us a yes or no by any specific date. There are several facilities across the state that have already said yes, and they're like ready to go. I don't think it's like a big deal, but I mean, places like that are already more set up for stuff like this, like Clackamas County, who already has all of this stuff going, and Lane County, who already have, like, those are counties that already are doing some of this stuff, so it's a little easier to implement. Places like Grant County, again, there's nothing against Grant County, but they just may not have the resources to do it, and I don't know if that's actually true. So it's going to be per county that we're looking at to help them. And if anyone's in the room that wants to advocate and help out, get application assisters inside of jails and such, always willing to talk about that, because I think that that's a big barrier, is the jail staff having to do the applications with the individuals. So that's, again, something that anyone in the community, if they want to help out their local jail or whatever, that we have trainings for it. And I've met with several jails and encouraged them to get connected with the community, because I think prior to COVID, the ugly thing, there was a lot more people going into facilities and assisting. And since COVID, I know in Department of Corrections, a lot of those volunteers, like, just it plummeted the amount of people that were going in versus now. It's getting back up there, but if you know people that want to do it, there you go. That's something that could be helpful across the state for sure. And OHA, we're going to be offering technical assistance, like what that process looks like post-release right now we're focusing on, and then what it looks like pre-release. We were kind of going, pre-release, we're going to help you, but then now that we have statutory authority, like, we're full steam ahead. We're going to have those benefits going sometime in 2027, which is amazing. And again, the facilities have the option to participate. The federal law that came down to the FCA, it requires Medicaid to offer the services and have them available. they can't mandate the correctional facilities to do that. So that it's a participation. I mean, that makes sense. Fortunately, a lot of our facilities across the state are really interested in this. So things like the CJC MOUD grants that a lot of the jails got really has helped boost this type of work. And so that's why I like to get this word out so we could team together and do this. So we could put more into this for our partners, because it's not that the jails or even the Department of Corrections or anything doesn't want to do these things. It's just the budget is the budget, right? So anyway, so that's good. There is a lot of good folks across the state pushing this work forward. And what community partners, again, I've already kind of alluded to it. People can team with their local jails. And then again, when we get pre-release services, this is an opportunity for in-reach providers. If anyone's an in-reach provider, they can go into the jails at that point in your local community potentially and bill Medicaid for it potentially. So there's a lot of potential for community partners, especially if this is your passion and like this is the population you want to help. I think it's the best population. I am a little bit biased because I think that these are the people that are going in and out of the system. And if we just give them a hand out, like it might take a couple times, but I think that we can make a difference and help these people that need our help desperately, that are, of course, in and out of our site and our communities, needing more assistance. There is with this, you have the connection. There's a CCO service guidance document that has really specifics about the details in there. I've connected our re-entry page on here, and there's fact sheet in there. And then again, the billing, the targeted case management billing guide is there too. I have a hand up. I think it's Heather.
Yeah. Oh, hey, thanks, Amber. That's super helpful. And I don't know if you know, but there's a couple questions myself and someone else wondering about who the contact is for becoming certified as an assister. And
good question.
And then the other thing is related to what you just have on this slide. Have you had technical assistance training with all the CCOs, or
Yes.
or they just received the guidance? Because technically, is there a different policy and procedure for a provider to be allowed to do this? I mean, normally, if it was a standard process, the provider would work with the facility, whether it's a jail or corrections. And then as long as they were in the CCO panel for the person, because it would go to the county of origin, as long as they're in contract with that county of origin provider and it's a pre-authorized, is the code pre-authorized or not? So that's another question. The CCO wouldn't have much to do with it necessarily if they're already in panel and it's pre-authorized, or if they're already on panel and has to be authorized each time. So I guess those are my kind of granular questions about the operational side of this. Because a lot of providers do have relationships with various entities, and this would be very instantaneous to implement if that was the case. In some communities, those facilities don't have those relationships, but there are already providers who could deliver the eligible services in the community and may or may not have worked with correction or jail populations before. So those are they might be terribly granular for you. I'm sorry.
Oh, no, I get where you're going. So I'm going to answer in two different parts, because the pre-release versus the post-release. So the post-release services, the CCOs are generally, if 97% of people are enrolled, there's 93% in a CCO. So generally speaking, it's their responsibility. And if the provider is contracted with the CCO in any capacity, then they could provide these post-release services. And I know that the CCOs are going to have, so stepping back as well, we've been working with the CCOs for years on these benefits, walking through them with when we had waiver benefits, and then now with this. So we have a work group with them. We created the service guidance document with them. So they're very up to date on what the expectations are, how it's going to look in the community, and assigning those care providers. They may not have the network, of course. And so the expectation would be CCOs, or if you're a provider and you're in their network, you could definitely reach out to them about providing these services, because it's already mandated as of January 1 of 26. It's in our statute for them to do it. We just haven't got the system fully up to date where they're getting notified. They're just not getting notified yet. We're still working out the details of the tracking and this and stuff I won't bore you with. But so that's one way to get, so and there's no prior authorization required for these services. So that's another thing. So and so then stepping into the pre-release, it's all going to be fee for service. So if you're contracted with fee for service, you could go talk to your jail and go walk into the, I want to say walk in because that's not how it works, but you can work with the jail at that point because it's fee for service.
It's not
Yeah.
how it works.
I know. So because I'm working corrections, like
I know.
Medicaid staff are just like, why can't you just walk in there? And I'm like, you have to have, like, there's anyway, it's just like, it's not that hard to do. And it's like,
I'm familiar. I used to do I used to do assessments and go in and do stuff. Yeah.
Yeah. And I've had to from the correction side saying, hey, Medicaid folks, you can't just walk into a facility. It's not like that. That's not a cowboy industry here. You can't just do whatever. So anyway, we're walking through those things. But if you are contracted with Essentra, you can go provide services in the pre-release period in 2027. So that's pretty cool. Again, none of these services have a prior authorization.
Oh, so I think I heard you say, the way you explained it, that while the pre-release services are all going to be done under fee for service,
Yes.
not under the county of origin CCO.
So the fee for service entity works in every county. So whatever county they're in, that's who the regional Essentra person will be assigned.
Cool.
So yeah. And really important, I'm glad you brought that up, with Department of Corrections and Oregon Youth Authority, they discharge to 36 counties, not just the counties that have their facilities. So all of the services will hinge on the county that they're releasing to. And
Cool.
and that's going to be, as we know, maybe tricky if you have someone in Multnomah County that's going down to Jackson, and fee for service has to do something. So there's probably going to be a lot of community engagement and contracting going on back and forth, because when they hit the door, they're still going to their assigned CCO.
But that's great, because in other situations, it's even for providers, it's frequently more complex, because they would have to reach out to the county of origin.
Yeah.
And then the new CCO. So that's great. There is no county of origin in this discussion. It's just fee for service, and then determining where they'll be released to and which CCO that is. So
Yeah.
Okay, that's
yeah,
great.
yeah,
Thank
yeah.
you.
So, and I want to, because I know that Essentra, the fee for service, they're all over the state, and so I'm assuming, again, I'm not in their inner workings, but I know that they have different people assigned across the state, so they'll probably work in that. But it is a full statewide system.
Yay!
So
You
yeah.
reduced admin burden. Good job.
Yeah. Well, there was a lot of different things we looked at doing, like the CCO is doing it, and then this, and then that became this, well, how are CCOs going to do it if they're over in Ontario? Like, that's not going to work. So anyway, this is hopefully the Essentra piece being the contact for pre-release should help. And is there Moxie?
Hello, I'm Moxie. I'm an addiction medicine physician, and I would love to work with some of these patients. There's kind of an echo. Hold on one sec. Is that better? Okay. So I just wanted to find out a couple of things. One is, I don't follow exactly what kind of work you would need people to do pre-release. And then if we were to have someone from our clinics contact these locations, what would they say? Would they offer to help them sign up for care after they leave? Would they offer to help manage care while they're in there, prescribe meds, therapy, peer support? Thanks.
Okay, so that it's a great question. So right now, what the relationship for pre-release services in the community is we're still working through that. Again, we just got authority to do it. And so we're going to have a lot more guidance coming out on that as far as how local providers can help, because I know that there's a lot of amazing providers out there that want to get involved and help this population, because you don't want to see them keep coming back into the system, right? So we're going to have more information on that. As far as the post-release services, the key with providers is knowing the CCO and getting connected with your CCO, because they're required to do it. And so they can enroll you and assign you as the provider to do that. But that's the key on the release, because technically they have access to their full Medicaid benefits upon release. So it's not just these services that you can do when they get out. And so there's an expectation, I'll go back to those, of the services that are required, but that once they have their full HP, there's no limitations, which is much, I think, better, because you're like, I know that they need this, but nothing's going to pay for it until they get out. So, yeah. And I honestly think that the biggest thing that's going to help to clarify in the pre-release period is just getting them connected, like getting them a doctor's appointment here, a doctor's appointment there. That to me is going to be the biggest help, because if you're in the community, you know that there's long waiting lists in a lot of counties, and there's just not enough that they can get in right on release. So the pre-release, that's what I think is going to be the best thing, is that care coordination piece. And if you're able to do it as a provider and provide TCM, or you have people that are in your office that can do that, that would be fantastic. And again, though, it goes through the CCO. In pre-release, it's going to go through Centra, so there's going to be a lot more flexibility, I believe, with that. So did I answer your question? I want to make sure I answered it. Okay, cool. I love questions. I am a teacher at heart. And yeah, so I think, Mitch, have I taken up too much time? Probably. I talk a lot.
I think we borrowed your time, and I'm very happy about that.
I love it. I love explaining this. I live and breathe this work. I work technically for the Oregon Department of Corrections, and I'm on a rotation over with the Oregon Health Authority, because I've done Medicaid, I've worked at the state hospital, so I've seen the system, and I see where we're failing people. And I've said this from the beginning, that one of the biggest places we're failing is as they get out, they're getting great care while they're in, and then you kick them out and there's this cliff. And then they're like, go manage it yourself. And they're struggling with other issues that, why they're anyway. So I see the gap, and I'm hoping that this can fix it. And I'm definitely one of the biggest cheerleaders for it. I attached on here as well, just for reference in the appendix, OARs that dictate the programs we have, the provider qualifications for targeted case management of those who can do it. And then our qualifications are here more specified. So that's just in the appendix. If anyone wanted more resources, I try to connect as many there. And then my email is in here. Feel free to email me anytime. If I don't know the answer, I will either pretend that I do, or I'll find someone that does.
Awesome. Thank you, Amber. That was a great presentation. And you're a very, very good presenter. That was very engaging. So, and also one more thing, Grant County has plenty going for it. Anyway,
I'm happy to hear it, and I am happy if they tell me that they're not interested. Again, I don't remember if they did. I'm sorry, my memory. But I'm happy to kick the can down the road and hey, how can I help you more, and be a pest.
It's just out in the middle of nowhere, but
it is.
Awesome. Okay, and thank you for all the information. Thank you for all the information. If there's any follow-up questions, your email address is in there. So again, thank you for being here and giving all that information. It is very exciting.
I will take a minute to make sure I address everything in the chat too, because I don't want to because I was presenting, I don't want to forget.
Yeah, perfect.
Okay.
Awesome. So we'll move on to the next agenda item, which we'll do some priority setting. And then, Mitch, there's slides. I'm sorry.
No worries. Ashley is trying to make me be better at accepting help and is going to share them on my behalf. I'm not doing
Oh yeah,
it.
it's just automatic. Thank you,
Uh,
Ashley.
Thank you. Again, this is like I'm coming from the wacky way of the world of doing it yourself. So this is great. Okay, so last time you and all of us got together, I was kind of sharing this really, for those of you that weren't here, I shared this really wild graphic about kind of like how all of our work goals tie into every single point in the continuum, and how, frankly, as the one person who staffs your committee, I'm a little worried on being accountable to you and delivering on those goals. So the hope is like, can we drill down on like where we're starting? And you all did a really, really great job giving me a bunch of questions to start looking for answers to. And around the same time is when we finally, I say finally as if finally because of my excitement, not because they took a while on this, just because I've been excited and wanting this. Our APAC data came in, which gives us a look at insurance healthcare claims from 2016 to 2013. I will say there's kind of some narrow looks, right? We're not looking at all claims because not all claims are relevant to this work. Like, I don't need to know what some folks did for a broken toe sometimes, would be the silly example for that. So this is a very specific slice of view and was done for very specific purposes. The hope is in future years, as we do this, we'll get better at working with this data. We'll start to increase our understanding of it, both its limitations and its possibilities. So I just want to kind of say that right out of the gate. The other thing to kind of consider for this data is it only includes individuals who engaged in a service in that period. So if you don't have an insurance claim, which there are individuals who have substance use disorders who seek no health care, or at least receive no health care that's in this claim database, they would be missing from that. So that's an important thing to also consider as we move through this. The next part of that is that because some parts, I think, kind of to your back and forth just now about Grant County, like some parts of the state have low amounts of folks living in them and living in them. And then as a result, there are lower numbers of folks who receive those services. So if any number I think was below 9, it gets repressed out of our data. So there's a likelihood that if you have looked at the slides, you've seen like these white areas in the state. That means there's nothing there to show. We already have a fix for that. I just didn't want us to get bogged down by that fix today because it does sort of complicate things. What we did is we've replicated some work that I believe OHA actually had started of creating some regional areas that combine different counties or combine different parts of counties just so we can not delete people from the data, but at least see where they might be interacting from. So no, we have that. I've just avoided talking about it today because it's a whole nother like realm of stuff to go into. The next part, I already said this, it's an evolving process. So there might be things in here today that you're like, wait a minute. On Friday, I also met with our contractors to say like, hey, here was some stuff that I found that I didn't want to present because I was worried about like I couldn't understand deep down what this meant. So they're going back through and cleaning that up and fixing some of those errors as well. And last, this is very high level, just so this is a point of entry for our work. This is really kind of me being able to spend the time looking to see what we had available to answer the questions that you all had, and then being able to figure out a starting place. And it emerged fairly quickly. So that's the kind of good news in that. Ashley, next slide. Okay, so treatment gaps. Now, this is a really fascinating piece of the data because I, as somebody who wants to understand limitlessly all of the things, was really hoping that we could just like kind of hit a number and understand what we need in the state. For those of you that have been around for a while, I think you know that that is like way too perfect of a solution and would be way too perfect and awesome of an opportunity. So what this actually means is of the people who received services or an insurance service in the state of Oregon in 2023 who had one of these diagnoses, this is the percentage of individuals who did not receive care. Now, you'll notice these averages are different. This is different by age. This is different by a lot of things. The thing that this most kind of similarly replicates in a lot of ways, though, is population density. I want to kind of like call that in a lot of cases. You can almost kind of look at this as an inverse of population. When we start to look at this from a like prevalence standpoint, there's almost like a where more people live, you see more prevalence of certain substance uses. So I just want to throw out those are some things that are in here. Now, There are some things that I think are very fascinating about this right out the gate, though. The first of those being that opioid and alcohol use disorders do make up the largest potential gap in our care system. That is notable for reasons. Oh, go ahead, Fernando. And by the way, as we're going through this, I've prepared time to be stopped and ask questions. So,
Yeah. Interesting way you phrased it. You said did not receive care. The question is, do we know if these were people who needed to have care? Not everyone who has a diagnosis, especially for some of the other ones like alcohol or cannabis, stuff like that, aren't always needing a treatment intervention.
you're raising up another hard challenge of what we all need to do here, which is to say that we did omit all remission diagnoses out of this data. However, that doesn't mean everybody uses remission diagnoses. So this is also one of those potential failures in here, is until we like, this could be an area that you all want to focus on, is like, do we start to work with providers to understand how to use those remission diagnoses more prominently? Is there something we can do to indicate like does not need treatment? There's other data sources that we need to do to sort of pad this in this, but this is just what the claims. So let's go ahead, Moxie.
Yes, thanks. I was wondering, when you say received care, I may have missed it if you said received care, meaning would you count that they went to the primary care and had an expert and a discussion? Or do you mean specialty care, withdrawal management, that kind of thing? It can be quite challenging, I think, in terms of method to use things like billing codes and diagnostic codes, because like you mentioned, I think you kind of alluded to, a lot of people don't apply those in a very descriptive way. So when we pull data in my practice, we'll often come up with people who look like they need care, but they haven't had alcohol in 10 years, but they still have alcohol use disorder on their problem list, and people bill for it, which makes it look like they're not receiving any help. So that can be tricky. And someone can be a heavy drinker, and sometimes all they need is an expert and a primary care doc to say, gosh, I think you'd do better if you cut down. And then sometimes they just cut down on their own. So yeah, but this is really a great snapshot, and I wonder about geography as well. Thanks.
Yeah, no problem. Heather, I'll take your question and then I'll answer yours and Moxie's in the same volley, if that's okay.
Yeah, same vein as Fernando and Moxie. Just, I'm sorry, having a key of what it is and isn't would be super helpful to this slide for me.
No problem. That is actually one of the to-dos that I asked our consultant, because I have their data dictionary, but the data dictionary explains the data kind of elements, not so much like what this means to the individual person. What I can say is this was the stuff that I was most nervous about early on. So there's kind of two answers to this. We didn't put expert on there because I did not want to say that a screening meant services. We wanted to be very clear. Screening meant an access point. We can pull screenings out separately in the future, but about actual treatment engagement, we placed that in the service settings themselves. If it was withdrawal management, that was a separate aspect, but for other like outpatient, residential, and inpatient, they have for outpatient and residential, where that line is drawn is an assessment occurred, a treatment plan building code occurred, and then an individual counseling session occurred. So we could at least say that there was some sort of ability to know behavioral health services were occurring. The problem is what they also tried to see like how far out they could see that, because lofty goal we had was like estimating utilization at specific levels of care, which just was for how many large numbers. Yeah, you can imagine what that did to our consultants. So
yeah, that's just really almost impossible to decipher. Yeah.
Yeah, and then the other piece to this is we did also, and you'll see this in a little bit, we separated out OTPs and MOUD services separately for a couple of reasons. And so there's a reason that I'm actually going to present a little bit of that in a few.
Okay, but so a key would answer all my questions, because it's interesting, but it doesn't really tell you a lot if you don't have a key. For me.
Yeah, and this again, this is just so I can show you something today that I found that I want to kind of cast for y'all. Next slide.
I am excited about the key.
We'll get it. So now here was a tale of two different, very drastic things that I saw in the data. And again, I want to kind of remark like a limitation to using APAC to do this. This doesn't mean that we have a like a 97% gap in services. This means that potentially up to 3% of, or excuse me, up to 97% of people could have needed the service and did not access it and did not access any other type of service. So that's where these higher numbers end up, because what you have is you have these lower numbers that show up in an outpatient setting. The thing that I want to kind of draw your eyes to, and I'm going to kind of move through the next 3 slides quickly so you can see what's visible here, is where these kind of higher rates of access happened, and then in your materials you can flip back and forth between this, but where those higher rates of AUD and OUD fall are also where these same gaps for withdrawal management exist right now. And similarly, can you go to the next slide, Ashley? Something that I also found very fascinating about the data is that where people have an OTP, that's the right side of the screen, and where people don't have an OTP causes some very interesting things as well. Where OTP exists, 58% of people receiving MOUD receive their MOUD from an OTP. Where it doesn't exist, 100% of all MOUD is received from a doctor, which is like kind of a no-brainer. But that also means that people aren't necessarily traveling out of their county regions in a lot of these cases too. So that means that those efforts to bring OTPs closer is providing a different menu of service availability. And the other thing that I want to throw out here, though, is for those counties or those areas where OTPs only exist, that is a much narrower, potentially narrower window of medication that you can get in either of those standpoints. Methadone would not be available to these counties where 100% of access is receiving from an office-based setting. So that's something to consider. Go ahead, Moxie.
Just wanted to raise the issue that when you have care from an OTP, you're also limited to only doing opioid use disorder treatment in those settings, unless they're integrated with a whole clinic and other types of services. So having worked in that setting for about 8 years total, it is extremely limited. So I had to dismiss a patient because he had ADHD and I wasn't allowed to prescribe him a stimulant for it, but he couldn't manage to go and get a psychiatrist and keep an appointment. And so his behavior became such an issue, he had to just leave. So having OTPs without wraparound care is also not really sufficient when you have polysubstance use and mental health issues. Thanks.
Yeah, you're actually capturing another piece that this is also kind of showing as it relates to inpatient or to withdrawal management is kind of the big focus where I want to think about too, is for the counties who do have withdrawal management and have an OTP, there's kind of like an in-system coordination they can do. For these counties that are only providing office-based care, you're now needing a primary care provider potentially to be able to kind of cross into the fold that a behavioral health it has and to say like, hey, can you help me with this person that maybe I'm less comfortable helping? Can you go to the next slide, Ashley? Because this is the other question that I wanted to be able to show up and answer for you all today. This also shows something fascinating is where the counties where we don't have OTPs, though. This graph on the right is the average caseload of prescribers providing buprenorphine throughout the state. What I think is very fascinating is you'll see these on the left, those very dark areas where 100% of MOUDs being provided by doctors, they have lower caseloads. The reason that I'm bringing this to you today is because one of the things that happened in the 4002 work was there was a lot of fears that we heard about people's entire patient censuses becoming their MOUD work. The data doesn't necessarily support that concern. The thing that this does show, though, is that you might have, there's a little blip here, by the way, that I think Katie could probably just point out as being Joel, but there are a couple outliers in that. But what this really does kind of say is that we could spread this workload more evenly across providers, but this also is going to mean technical assistance. This is also going to mean training, and this is going to mean like a very intentional outreach to figuring out how you bridge the physical health space into behavioral health to have that integrated system that Moxie's saying like without is a little bit more complicated. And I think from like a value perspective, from what you all told me last year, is you wanted to shore up those transition spaces. And so the thing that I've been really thinking about as I looked at these two graphs in particular, knowing that the withdrawal management gaps, Ashley, could you go back 2 slides? Knowing that these gaps for care are specific to certain counties or higher in certain counties, my head started to go, what happens if you leave a withdrawal management program and have a medication for either alcohol use disorder or medication for opioid use disorder? What is your access look like? What are the transition challenges that you might have? And as a result, what are the things that we're actually placing on providers to do more of as a body, this treatment committee is saying we want to shore up transitions, we want to improve the speed of access to care, which to me started to kind of say like there are less withdrawal management programs. This might be a body of work we could move on a little bit faster and have a greater impact than starting lower in the continuum. So that's kind of my ask for you today is, does that make sense? Is that worth the salt? And then there's obviously a discussion I want to have, but I see both your hands.
Yeah, no, I appreciate that thinking, Mitch. And it just makes me think too, another component that this data can help us chew on is the inability to, in low population areas, for scale that allows people to be sustainable. And we can't forget that. And so with this data, we have some really interesting things to think about, and particularly around methadone, which has, higher anyway, to give people choice to medications that may work better for them in regions where robust infrastructure is more difficult to be sustainable because the number of patients is just going to be lower because it's a smaller population. And that's just, people are running into that all the time in Oregon, that they can't sustain operations because they don't get the referrals and the patient numbers that they need, which makes it really awful for folks who need those services. Yeah. Okay, thank you. This is really interesting. I appreciate that.
Yeah, and I'm glad, and then this is something too that I wanted to kind of make sure that I'm saying out loud too before Fernando says asked you chime in. Art had kind of brought up that same concern, I think, in January's meeting to say like we're talking about expanding, we're talking about this, but like how do we sustain that? And I think that this is exactly to your point, like how we kind of stay on top of it. Go ahead, Fernando.
Yeah, well, I mean, thank you. And kind of to continue on that train of thought, one of the key questions that I had in the Red subcommittee in January was, in these places where we're seeing the gap, is this a lack of providers? Is this a lack of credentialing? Is it because how we address this is going to be driven a lot by that question, because it's a big difference between there is no one there versus there's people there who aren't wanting or don't have the willingness or the waiver to actually provide those medications. And that I think is a very key question, because we can't just assume that this is a lack of just access to the service, or lack of desire. It's just that maybe the health systems in those areas just aren't interested in actually providing that service. And that's a much different issue to solve for.
I am really glad that you're flagging that too, because I think I also want to be very mindful to say that this is a single data set. And I think that this is my ask too is also like, if you all agree that withdrawal management is an okay starting focus. And Ashley, I think I just moved the slides around. Can you go to the summary slide? It might be like in like 3 now. I'll keep going. There we go. This is kind of to Katie's point. There is a withdrawal management facility in Umatilla that's empty. This is based on data that I received back in September about where different locations are currently at. This is where withdrawal management programs that are licensed existed in September of 2025. Go ahead, Fernando.
Yeah, I guess, one of the questions that I always want to ask when we're doing this stuff, is the common statistic that gets thrown around is how bad we are in access to care in the state. But the second half of that bullet point needs to be how much we spend, and we're right around 13, 15, somewhere in there. So we're spending a ton of money, but not getting value for our dollar. So I guess one of the things, if we were to move forward with this, and in line with the fact that we do have some budgetary oversight as part of our mandate in this group, is to see how much is being spent regionally on providing these types of services, because often we're talking about not having enough resources, but what I'm really saying is that we have plenty of money we're putting in. We're just not getting the value out of what we're doing. And that's again a much different proposition than there's just lack of access to care.
That'll be, I will say, like the opportunity that we have right now is the ADPC is doing the kind of financial study. I don't know how much we'll be able to glean from like a county by county, but that's something I can kind of sort of think about as we're moving through that process. I do think one question that I've definitely wrestled with internally is we did pull the cost effectiveness part out of the definition of the EDPC in the last statute update. And so my question is like, where do you want that line to be drawn, or imagining that line can be drawn of like cost effectiveness versus just like, where is the money going and where's the money be like impacting? Like, are those two different things or are those the same?
Sorry. I know because I saw Heather and Art raising their hands, and I think that getting data points on both as a way to make a better decision is important. Because I think, again, we did this rural health initiative meeting on Monday where we heard about $1 billion, about $200 million a year that's about to go into the system for places that are saying that they don't have enough services. The question is, why don't they have enough services? Is it purely a funding model issue because we are spending so much money? There has to be some kind of, I don't know, I'm trying to figure out like some sort of Venn diagram around where the access to care is and what's preventing it from being larger. Because it's not the system that we have is constantly going, we don't have enough, give us more money. But then they can't prove to us what we're doing with all that money that they're getting. And that is what's increasingly becoming difficult for our legislative partners to continue to fund. When we go to them for money, they're like, why do you need more money? We gave you
So
a ton
really yours
already.
is viewing like allocation as a data point, not necessarily as like any sort of, okay, awesome. Okay, that I can definitely do my magic on if I can. I did see Art. Is it okay if I is that relating to what Art was asking? I just know that no offense, Heather and Moxie, but I will want to make sure that I'm also attending to other folks that have just raised their hands also and haven't spoken.
Yeah, on that around just the data points on the financial things, there was a research done that Oregon went from 47th to like 42nd as far as access. I really think that there's a level of quality that is missing across. And as far as the outpatient, my concern around the interest in the MOUD services is OHA or whoever trying to move more of the withdrawal management, especially with the Suboxone and stuff that's been sitting where you don't need a COA to be a substance user to provide, like there's medical providers that can provide that without going through that whole COA process. Is this work going to try and change that system where it's going to create more red tape? Or is it going to help align it within the current system in place? And I don't have the answer. I just have the question.
No. This is why I'm here. I'm here to be able to sort of kind of support those questions. So something I will encourage folks to do if you haven't done it in a while. Ashley, can you go to the next slide for me? One more slide actually, and then oh, actually, where did I move these? Just says short-term goals on the top, wherever I put that one now. I moved some stuff around on Ashley. One more. There we go. In the treatment page, it has kind of, and because I want to make sure that I'm bringing everybody back to why this is all happening. You all, over the course of the previous year, designed what I hope to be a very successful 5-year plan for addressing substance use prevalence, deaths, and disparities throughout the state of Oregon's treatment continuum. On the webpage, there's a reason I'm pushing the webpage out is because that document that plan included both the current assessment, short-term, midterm, and long-term objectives of where you all hoped this would go. In the short term, this is the stuff we have to accomplish before we can do any of that long-term stuff that I think you're kind of referencing are like what will fundamentally change about how we invest, how we expand, how we do all those things. What I know, and go ahead to the next slide real quick, Ashley. is that our first steps were to do a bunch of assessment of all of these points of the continuum. And I'll be kind of frank with you all. If we're to do this with all treatment providers all at once, I think they'll probably one, hate us, and two, probably like the amount of information we'll be trying to pull in and discuss is just going to be too much for us. And I mean that like knowing the intelligence that's in this room. So I think that what I'm basically saying is, can we titrate all of our plan into just focusing on withdrawal management for the next period of time, so we can start surveying providers and surveying data, getting, I'm already working with both licensing and certification to try to figure out like, can they tell us those common things that are maybe early findings in those first year reviews they've been doing with withdrawal management programs, so we can start to influence like the quality that you've all been hoping to kind of see improve. And similarly, working with the team at HPA to get some data elements out of MOTS, because the cool opportunity we have using older claims data is we also already have older MOTS data to reference for all of this. So also working to figure out, because there are three things in that data that I'm very curious about, specifically with withdrawal management, is where are people getting referred from, where are people getting referred to, and what are those outcomes? Those are things that I think will inform a lot of the questions that you're asking today. Then at that point, this kind of gives us the ability in the background to be able to, I'm going to say, like, through working in these committees and the MOUD work group that we've talked about, as well as that best practices, evidence-based practice work group, collaboratively design those surveys to figure out this information from the providers themselves and be able to build those relationships up for the later other stuff that you want to do that is indicated in the plan. So it's like all of those are a yes, though what that looks like, and I mean this like wanting to believe that I'm as smart as I think I am. There is a probability that we get to the end of this year and then go, we had something wrong about all this. We actually need to go do this, and that's the process I don't want to rob us from. If that makes sense. My thinking here, and then I'll be quiet because I'm realizing that I'm going over on time, and I know there's still two hands up. My hope, my ask today is what we could do is use the April meeting to be able to have this group very much clarify what you hope the deliverables of the MOUD work could be as it relates to withdrawal management, what you want the deliverables to be for the best practices and quality group, and then how this committee plans to interact with them moving forward. A reminder, can you go to the slide that has like the big arrow on it, Ashley? There it is. This is sort of like where all that could fit. My hope is, again, like later in the month of April, we can start those work groups if we're ready. If we still need to form them, then that's okay. It gets pushed to May. But this kind of enables us to start doing the waitlist management survey to identify our priorities for TA and start to roll this out as a combined like a plan for how to implement and get all that information you all wanted. Heather and then Moxie.
Sorry, wrong click. Thank you. I agree with your strategy. I think it makes a lot of sense. I think it's a manageable size sector that we can really dig in. To Fernando's point on the financing, I think that might be an interesting opportunity just to get information from other committees. I know I'm not on the MAC anymore. I did my 4 years. But other committee, and that's one of their things. And I know the team here at ADPC is really big on collaboration across commissions and committees. I'm aware that the Oregon Health Policy Board and actually interesting CCO data on costs in a meaningful way from the Universal Healthcare Board, because they had to really dive into costs for their developing their proposal. So they actually had 2 really large studies that are pretty interesting. So my ask would be, once we get into the work on withdrawal management, to kind of get some summaries from some of those peer commissions to give us enough data to understand, because our healthcare costs, the key the key is the key, what's included and what's not included, and in various studies different things are included. So how much is admin burden? You know, you can't really compare West Coast costs to costs in the South, right? So it's not apples to apples when in our ranking. And so they've done some interesting things in different committees. So that's my 2 cents on that. Because it would be nice to have some of that information as we develop proposal, but I don't think we have time. And other committees are doing that very thoroughly.
Go ahead, Moxie.
I just wanted to call your attention to some info I put in the chat, which essentially says that 95% of people with SUD do not want treatment or seek it in any given year. So if we design a system that will accommodate everyone with SUD in the whole state, it will go bankrupt really quickly. So that's all.
I think that that's going to be an interesting thing that I've wondered how that shows in our data. So I'm glad you're flagging. Go ahead, Fernando.
Yeah, and if anybody who's worked alongside me knows that I'm a verbal processor, so I haven't really thought this out too well just yet. But I guess this is a general sort of question or just something to put out for the entire group here. Given that we know we're seeing a Medicaid contraction in 2027, I feel like it'd be a good just working part of our working together on all this stuff is to have the financial constraints that we are facing in mind. We can't, unfortunately, for at least the next 1 to 3 years, really make any meaningful plans that don't have that Medicaid contraction in mind. And to Moxie's point just now, we can't actually pay for the system that we're trying to build. And I think value for our dollar is going to be a key element in everything that we do, especially again, because our legislative partners are telling us there is no more money and there's going to be even less in a year. So this is more kind of just in general as part of our working is to just kind of have numbers around that in our mind. So
yeah. And Fernando, I totally agree I'm sorry, I'm jumping the line, Mitch, but I know we're short on time. OCBH, we have 60 agencies, so pretty large percentage, and particularly withdrawal management, pretty large percentage of withdrawal management represented in the membership. And we do, to not reinvent the wheel, we do regular annual as part of our dues process membership survey, and then we can do really quick survey monkeys to gather data. And I'm happy to bring it to this group. We do that all the time, so I can probably help ease the burden for providers and the committee and the staff if there's data, because we do know people are already doing, because of the CCO contractions, are already doing program resizing and layoffs and all kinds of stuff. So it's real, and we're not even into HR1 yet.
Yeah, and I want to also like again, and I'll be sure in the kind of follow-up email like kind of detail like where all these like I know when I say survey, like we could use assessment or whatever we mean in that. See, like CCO membership is also, or CCO representatives are also somebody we intend to get in contact with. I already am starting an email thread for a Tri-County Area 1 to even come present some data to you all.
And Mitch, are you able to sort in the all claims, all payer for people who also have occurring like psychiatric disorder? Like, you know, we've talked a lot offline about this sort of chronically SPMI clients who maybe their SUD is not even their substance use disorder is like maybe third or fourth even on their list of problems. However, they get lumped. They are a huge utilizer of the system that kind of gets lumped in and skews the data as well.
We did not exclude that population from the data set, but I do think it is an interesting. We have like some ability in the current data of like how we've been able to split things based on like not that reason, but some others. And so that might be an ask that I can probably try to sneak into this one. If not, that's something that I can ask some of our CCO partners or OHA to maybe fill in the gap on. Yeah, I'm realizing the time. Ashley, is there any public comment?
I have not received any written public comment. Thank you.
Mitch, you were muted.
I like how I muted and then unmuted. I'm like sitting here unmuted. I think Devin has his hand up for public comment.
Thank you for letting me unmute and join your guys' fabulous meeting. Lots of great information. I really liked the discussion today, and there was a lot to learn. And just kind of piggybacking off of Fernando and Art on really wanting to see where those numbers produce outcomes and seeing like keeping track of our budget. I've been working in the field for the last 15 years, co-founder of 4D, and then doing recovery housing for like the last 11 years. And I was at the last meeting for the ADPC where I was saying that I want to be more involved. So I will keep coming around and be here month to month to see how I can also get a nominee to be on one of the boards or one of the committees to help our great state of Oregon.
Devin, I just want to double check. I think this has already been asked in another committee. Have you used the application link or received that? If not, I'll make sure you got that.
Yeah, Tony sent that over to me, and I sent over my resume and information, and I sent previously an message bugging Ashley Olson, but she got me all the stuff that I needed. She's super on top of it.
Great. Well, thanks a lot, Mitch, for putting all this together. Thanks everyone for really lively and intense conversation about some of these really important topics. And we look forward to seeing you all next month and continuing to work on some of these pieces as we move forward to sort of strengthen the SUD care system that we have here in Oregon. So thanks, everyone. Have a good rest of your week.